Manoj Prathapan sir for his talk.
Good afternoon, everyone. At the outset, let me thank Dr. Sweta for giving me this opportunity. I'll be talking on understanding the angles in glaucoma. So, why is this important? To understand the angle, the mechanism of glaucoma can be varied, and this can affect the course of the disease. Some of the type of glaucomas present as a quiescent type, like primary open angle glaucoma. Some of them will have a very aggressive course, like neovascular glaucoma or an acute angle closure crisis. And the treatment is also appropriately directed. I will not go into the details because Dr. Earlier already mentioned about the normal angle structures here. Just a video about how a normal pigmented angle looks like. You can see the iris, the root of the iris, ciliary body, scleral spur, pigmented trabecular meshwork, anterior trabecular meshwork, and the pigmented schwall baseline. Let us classify the disease into open and closed angles. Occludable angles we'll come to it later. So what is open angles? How do you know if the angle is open? On slit lamp examination, on straight gaze gonioscopy, if you see normal iris configuration with visible aqueous access to posterior trabecular meshwork, we can call the angle as open. So what are the types of open angle glaucomas? We have primary, where there is no other ocular causes for leading to glaucoma, and secondary, again we have three types: pre-trabecular, trabecular, and post-trabecular. This is an example of pre-trabecular glaucoma, neovascular glaucoma. You can see neurobiosis iridis and neovascularization of the angle. This is a trabecular type of glaucoma. There is marked increase in the pigmentation of the angles. This is again another type of trabecular mechanism, angle recession glaucoma. Post-trabecular, raised ESVP, dilated episcleral veins, and blood in Schlemm's canal. Next, coming to closed angle glaucoma, we again have primary and secondary. Primaries have pupillary block as a component, whereas secondaries can be with pupillary block and without pupillary block. Without pupillary block can be pull mechanism and push mechanism glaucomas. Now let us figure this out with iris configuration. So what is the normal iris configuration? There is a mild convexity anteriorly. This is because of relative pupillary resistance, which every one of us have. This causes a pressure differential between the posterior chamber and the anterior chamber. The posterior chamber pressure is slightly more than the anterior chamber. This causes the iris to be slightly convex anteriorly. When this is exaggerated, we have pupillary block and a exaggerated convexity of the iris, causing shallowing of the peripheral AC. The central AC is formed. This is a sign of pupillary block glaucomas. This is a clinical photograph of a secondary pupillary block glaucoma. Another example. Next is steep iris configuration. So in this, there is no pupillary block. The entire iris is pushed forward. Classical examples are aqueous misdirection syndrome or choroidal effusion. So here, the central as well as the peripheral AC is uniformly shallow. This is an example of aqueous misdirection syndrome, post-trabeculectomy. You can see the angles opening up after mydriatics are used. Now the angles are open. For these push mechanism glaucomas, you can see the ciliary process through the pupil when you do a gonioscopy. Next is tended up in the periphery. These are in pull mechanism glaucomas. The central AC is formed, and in the periphery, the iris is pulled up. These are seen in uveitic glaucomas and neovascular glaucomas. Other examples are also there. So here you can see multiple focal passes in the angle. There is no pupillary block here. The other iris configurations that we can have are flat iris configuration and concave iris configuration. When do we call it narrow or closed angles? On straight gaze gonioscopy, if you see negative visible aqueous access to the posterior trabecular meshwork, we can call it narrow or closed. So the possibilities are either it is occludable angles or closed angles. So what do we do when the straight gaze gonioscopy is not showing angle structures? Then we should do a manipulative gonioscopy, where we try to see over the hill. So if you are able to see the angle structures, That means it is an occludable angle. If you're not able to see, it could either mean there is an iridotrabecular contact or a synovial closure. If it is negative, then to differentiate between ITC and synovial, you can do an indentation gonioscopy. If the angle structures become visible, it is an iridotrabecular contact. If it is not visible, it is a synovial closure. This is just a representation. You can see the convex iris configuration suggestive of pupillary block. Angles are not seen. Once you do indentation, the anterior chamber pressure is raised and the iris is pushed backwards. On the right side, you see the angles opening up. On the left side, it is not opening up because of synovial. This is a clinical picture of indentation from gonioscopy. You can see there is no angle structure visible. After indentation, the angles are open. Next, coming to a plateau iris configuration, this incidence is about 32% in patients with post-PI. This is because of an anteriorly inserted ciliary body. The anterior chamber depth is fairly normal. There is an element of pupillary block in most of these cases and YAC PA is warranted. If angle remains not visible in spite of patent PA, think about plateau iris configuration. If the IOP is high in these situations, we call it plateau iris syndrome. This is the classical double hump sign that is seen in plateau iris configuration. Okay, that video is not playing, sorry. So you can see in this photograph there is anteriorly placed ciliary process and the iris has to climb on top of that. So when you give indentation gonioscopy, the middle part of the iris concaves backwards and the two convexities are because of the lens convexity and the ciliary body convexity. Let us grade the angles. We are using Schaffer's grading. If the angle is wide open, if the angle width is more than 25 degrees, if you can see the scleral spur or ciliary body, we can call it 3 or 4 and the possibility of closure is impossible. If the angle is about 20 degrees and only up to trabecular meshwork is visible, it is still narrow and the probability of closure is possible. It is extremely narrow if angle width is 10 degrees and we are able to see only up the Schwalbe's line or ATM. In these cases, the probability of closure is eventually possible. A complete or partial closure is when there is iridoperipheral AC contact, angle width is 0, the corneal wedge is not identified, and probability of closure is present or imminent. Thank you.